Definition of acute abdomen is any serious acute intra-abdominal condition attended by pain, tenderness, and muscular rigidity, and for which emergency surgery must be considered. Next. So first, we need to know the anatomy of abdomen. So first of all, abdomen can be divided by regions or by quadrants. So by region, by quadrants, it is divided into 4 quadrants by the midline plane, and transumbilical plane. So there are 4 quadrants, which is right upper quadrant, left upper quadrant, right lower quadrant, and left lower quadrant. And for the regions, it is divided by the 2 midclavicular planes, subcostal plane, and intertubercular plane. So there are right hypochondriac.
So, if you are to choose, which one do you choose? The regions or quadrants?
Region.
Regions, more specific lah kan? Alright.
Okay, so we have right hypochondriac region, epigastric region, left hypochondriac region, right lumbar region, umbilical region, left lumbar region, right iliac region, hypogastric region, left iliac region. Next. So, why is it important for us to know the anatomy of the abdomen and the region and content of abdomen? Because in each region or quadrant there are underlying organ, and each organ have different pathology. So for right hypochondriac, we have organs such as liver, gallbladder, small intestine, ascending colon, transverse colon, and right kidney. So for epigastric, we have esophagus, stomach, liver, pancreas, small intestine, transverse colon, spleen, right and left kidney and ureter, and right and left adrenal glands. So you can see the picture that we have put in the slide to know which region have which organ. Okay, next. So we need to elaborate more on the abdominal pain. So when the patient comes with abdominal pain, we need to know first is the site. So which region or quadrant. Second is the onset. When did the pain start? Acute or insidious. Character of the pain. Pain can be sharp, dull, heavy, or burning sensation. Next is the radiation. Where does the pain travels to? Where does the pain travels? Somewhere else in the body. Next is the associated symptoms that come along with the pain. And next is time. When does the pain occur? Does it happen at a specific times of the day, or is it constant? Next is exacerbating or alleviating factor. What makes the pain better or worse? Certain medications, physical position, and etc. Next is the severity scale from 0 to 10.
Okay, Fadlan, sekejap I stop sikit Okay.
Okay.
Right. So, character. The most important thing is the character of the pain. Yeah. So, sharp, dull, heavy. Apa maksud dia? Heavy tu macam mana?
Heavy, like crushing, right? Macam ada pressure.
Okay. So, the characteristic of pain will determine the origin of the pathology. Macam contoh kalau sharp pain. Sharp pain usually due to what?
Sharp pain.
Sharp burning pain. Sharp and burning pain.
Sharp and burning pain.
Selalunya burning pain.
Burning pain biasanya dekat like fatty ulcer disease yang macam ada acidity.
Dia biasanya disebabkan oleh chemical, kan? Chemical irritation. Contoh pancreatitis, gastritis. Gastric kan acid kan? So, what about dull aching pain? Dull aching pain.
Dull aching pain.
Where organ, is the origin? Organ which is?
Like the liver, spleen.
It belongs to solid organ. Correct. Alright. Dull, heavy itu biasanya is solid organ. Belongs to solid organ. What about colicky, which is you don't mention here. Colicky pain.
Colicky pain is a pain that is coming and going in wave. And
Yang
each
tu belongs to which organ?
hollow organ like the small
Hollow
intestine.
organ. Yes, correct. So any hollow organ, tak semestinya colon or small bowel, it could be the duct, kan? Macam CBD, common bile duct. Okay, so because you are in the foundation, so this is the things that you have to remember. Ya, senang saja. Alright, okay? Okay, continue.
Next.
Baru ni you all ada kelas mengenai approach to chronic abdominal pain kan? Ke grup lain?
Tak ada lagi rasanya.
Ada lagi. Okay. So how do you how do you group this patient is acute, this patient is chronic. What is the duration?
Less than 40 days is acute.
Less than 14 days. So kita ambil 14 hari, 2 minggu. If it is more than that, that is belong to chronic illness, chronic abdominal pain. It's no more acute. Yeah. So that is the duration. Okay, continue.
Okay. So there are 4 types of abdominal pain. First is the somatic pain, which is originate from the abdominal wall and parietal peritoneum. So it is sharper and more distinct, and the patient can pinpoint where the pain comes from. And it is usually due to irritation and inflammation of the parietal peritoneum. And it is sensitive to cutting, tearing, burning, and crushing. Next is visceral pain, which is originate from the internal organs and visceral peritoneum. It is achy and crampy and difficult to localize. And it is not sensitive to cutting, tearing, burning, and crushing, and sensitive to stretching of walls of hollow organs and capsule of solid organs. Next is
Apa
shifting.
maksud stretching of wall ni? Apa maksud dia?
Stretching of walls.
Maknanya apa?
Macam contoh kalau ada gallstone tersekat.
Stretching of wall ni, stretching lah maknanya bowel dilatation kan? Bowel ni kalau kita cut, kita tak rasa apa-apa. But if we picit ataupun is dilated, baru dia sakit. Sama dengan liver kan? If the capsule is stretched, maknanya it is enlarged, baru dia cause pain. Okay?
Next is shifting pain, which is pain that change location over time, parallel to the cause of underlying disease, such as peri-umbilical pain shifting to right lumbar quadrant.
Mana right lumbar? Right iliac fossa.
Right iliac fossa in acute appendicitis.
Right iliac fossa. Okay.
Next is radiating pain, or we call referred pain, which is pain is felt at a distance from the source. So, for example, pain radiating from loin to groin in ureteric colic, or pain felt at left shoulder in the case of splenic rupture. Next. So this is next is acute upper or middle abdominal pain. Next. So for the right upper quadrant pain, we divide into 2, which is biliary or gallbladder. First is biliary colic, second is acute cholecystitis, third is cholelithiasis, next is acute cholangitis. For the hepatic, we have acute hepatitis, perihepatitis, liver abscess, and portal vein thrombosis. For the left upper quadrant pain, we have from the spleen is splenomegaly, splenic infarct, splenic abscess, and splenic rupture. Next. So, next. So first is the cholelithiasis or biliary colic. The definition is it is a pain occurring when the gallbladder contract against an obstruction. So we need so there are three types of gallstones, which is cholesterol stones, pigment stones. Pigment stones consist of two, which is either brown or black, and mixed stones. So the clinical feature for biliary colic are it is intense, thus dull discomfort at the right upper quadrant or epigastric region, and it is resolved after a few hours. Tenderness over the gallbladder during acute episode. It is associated with nausea, vomiting, and diaphoresis, and usually precipitated by eating, often fatty foods. So the investigation that we are gonna do is the first is the liver function test. There is increase in ALP and ALT. There is increase in bilirubin. For the full blood count, there is leukocytosis, and we will do ultrasound scan. Next. Next is acute cholecystitis, which is so when there is a mechanical obstruction of the cystic duct or the gallbladder neck by the gallstones, and when there is a prolonged obstruction, it can cause inflammation due to the concentrated bile. So the clinical features are first is the severe continuous right upper quadrant pain, and it often radiates to the right flank and back, associated with anorexia and pyrexia. So there will be tenderness and guarding of the right upper quadrant, and there will be a positive Murphy sign. So for the investigation, for the full blood count, increase white cell, and for liver function test, increase AST, ALT, increase in alkaline phosphatase because there is obstruction, increase in serum bilirubin. So for the acute cholecystitis, the diagnostic test is the ultrasound scan. So there are 6 findings that we can find from the ultrasound. First is the positive sonographic Murphy sign, because we will use a probe accurately placed over the gallbladder sign, so it is more accurate. Next, there will be impacted stone in the cystic duct or the gallbladder neck. So next is the thickening of gallbladder wall, more than 3 millimeter. Distension of the gallbladder lumen, more than 4 cm. And there will be a stone, calculus stone with acoustic shadow and pericholecystic fluid collection. You can refer to the photo on your right for the ultrasound scan.
Okay. So Fadlan, you pilih siapa yang you nak tanya.
Pilih.
Pilih. Nama ramai-ramai tu, ya most favourite ke, the least favourite you?
Mustaqim.
Mustaqim. Mustaqim ada? Mustaqim. Apa beza biliary colic dengan acute cholecystitis? If you can understand from what Fadlan has discussed just now. What is the difference?
Kalau if cholelithiasis is a stone inside the gallbladder, but acute cholecystitis is an obstruction. That means if there is a bile going to the gallbladder, it cause obstruction. So that was pain, and that is cholecystitis, cause inflammation. But cholelithiasis, it doesn't mean it can be asymptomatic, but acute cholecystitis of always like having symptoms.
Okay, so correct. So it is a progression of the disease, kan? Daripada just ada stone, lepas tu dia cause inflammation. Tak semestinya obstruction. It could be because of the the trauma ke, kan? Dia duduk kat situ, kan? It cause inflammation. So bila inflame, there will be more symptoms such as apa? Symptoms dia.
Severe colicky pain.
Okay, yang tu pun severe pain juga. So apa? Apa yang beza daripada segi presentation? Because this is now patient has inflammation.
presentation cholelithiasis dengan cholecystitis ke doktor?
Cholecystitis tu dia dah naik satu tingkat dah. Dia ada inflammation. So what is the difference? Apa dia tambah daripada pain? Semua ada pain. Kan sama je sebab semua ada pain. Cuma apa yang beza? Yang you kata, okay, this is already acute cholecystitis. No more biliary colic.
Bilirubin jaundice.
Presentation, clinical.
Right upper quadrant pain.
Sama. Kan Fadlan kan?
Sama ada. Dua-dua ada right upper quadrant pain.
Macam mana ni beza? This patient, you nak letak diagnosis as acute cholecystitis. What is the difference?
Kalau dari laboratory apa? Investigation boleh ke?
Nantilah I tanya clinical features. Ada tulis kat situ.
Radiation doktor?
Sama je.
Murphy sign doktor?
Inflammation. Dia?
Murphy sign.
Murphy sign is fine. Symptoms dulu.
Pyrexia doktor?
Fever.
Fever. Okay.
Kan. Bila something is inflamed, what happen if any inflammation in the body, there will be increase in inflammatory proteins and cytokines and all that, right? Tumor necrosis factors, right? So patient may have fever, which is different from the usual or initial presentation when patient has just cholelithiasis, no inflammation. So when patient has fever, now the diagnosis could be acute cholecystitis. Faham? And then when you examine, yes, patient ada positive Murphy signs because of the inflamed peritoneal, parietal peritoneal there, kan? Peritoneal dia ada dua layer, satu visceral, satu parietal, kan? So when the parietal peritoneum is inflamed, it will give the somatic pain. So bila you tekan kat situ, dia akan bagi somatic pain when you touch the inflamed parietal peritoneum. So that will give you clue this is acute cholecystitis. So baru it will support with your investigation. White count is high, kan? Ada some sort of infection and obstruction, kan? Derange sikit dia punya liver function, serum bilirubin could be higher than normal, macam tu, right? And ultrasound you will find there is stones and also inflammatory process that we can see from the ultrasound, which is thickened gallbladder and pericholecystic fluid because of the inflammation. If it's only biliary colic, you cannot see all those signs in the ultrasound. Okay?
Okay, doktor.
Boleh? Okay, proceed.
Next is the cholelithiasis. Cholelithiasis, which is the presence of gallstone in the common bile duct. So the clinical features are there is right upper quadrant pain or epigastric pain, nausea and or vomiting, and there will be obstructive jaundice. You can see the patient have pale urine and pale stools. So the investigation is first liver function test, increase AST, ALT, increase in serum bilirubin, increase in alkaline phosphatase. Next is ultrasound. The findings are dilated common bile duct more than 8 mm. Stone in the stone in common bile duct not always visible due to bowel gas. So we need to do, if the stone cannot be seen, we need to do either ERCP, endoscopic retrograde cholangiopancreatography, or MRCP, magnetic resonance cholangiopancreatography.
Okay. So now it all already progressed. Dah ada obstruction, stone. turun ke bawah tu obstruct there. Kan? So, there will be obstructive jaundice. Selalu patient macam ni, dia akan dapat ascending infection. What do you call that?
Ascending infection.
Sebab obstruction tu.
Is
Ascending
cholangio
cholangitis.
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 Ascending
ascending
cholangitis. Okay, so are you going to talk about ascending cholangitis?
Yes.
Tak apa, okay. So tadi you cakap, right, so dia punya AST/ALT high, serum bilirubin, yang ni tinggi lah, tak sama dengan cholecystitis just now. Cholecystitis just now, patient mild or tinge of jaundice, bilirubin pun dalam 30 je. Tapi kalau yang macam ni, bilirubin high, 80, 100 kan? Right. So ALP is very high compared to AST and ALT. Right. Why? Why ALP is more prominently high compared to AST and ALT in obstructive, in choroidocholithiasis? Anybody can answer?
Repeat the
Sometimes
question.
AST and ALT normal, ALP yang high. Kenapa?
Because AST and LT is more specific to liver, but LP is toward the biliary tract.
Bolehlah jawab, tapi tak panggil apa, tak spesifik. Tak macam medik. So because ALP is produced by cells in the duct, whereas AST and ALT are produced by parenchymal cells, which is liver cells. Okay, that's why when it is high, it means the cells yang terlibat is in the ducts lah. Faham? Ductal cells, ALP. Okay, selain daripada ALP, what about serum bilirubin? Macam mana kita nak tahu this is obstructive? Post-hepatic jaundice. Ingat lagi tak? Kita ada pre-hepatic, hepatic and post-hepatic. So this is post-hepatic jaundice. How do you know from the serum bilirubin? Tengok kat atas tu ada turun wahyu.
We see indirect bilirubin, right?
Direct and indirect. So which one will be high? Direct ke indirect?
Indirect.
Kenapa? Betul ke? Indirect ke direct? Post-hepatic.
Direct.
Conjugated kan doktor? Conjugated bilirubin.
Conjugated bilirubin. Conjugated tu direct ke indirect?
Entahlah.
Entah.
Direct.
Ada
Direct.
jawab entahlah.
Direct doktor.
Direct.
Aduh, ni lama sangat PKP ni. Okay, direct bilirubin. So, bukan only ALP, not only ALP, you have to look at the bilirubin, whether the direct or indirect bilirubin is higher, right? So those will make you, guide you to give the correct diagnosis. Alright, okay. So ERCP, nanti sekejap, tak habis lagi. ERCP. ERCP is diagnostic and therapeutic, kan? Betul?
Betul dah.
Betul, Fadlan? Diagnostic, you boleh tengok ada stone ke tak dalam CBD. Therapeutic macam mana therapeutic?
Boleh apa tu? Macam boleh buang gallstone tu guna ARCP.
Dia boleh blast the stone, dia boleh remove the stone during the procedure. Okay, satu lagi dia cakap situ, CBD stone not always visible due to bowel gas. Right? Kenapa? Because ultrasound is sonography, ultrasonography sounds. So sounds will move very poorly. Sound waves move very poorly in the gas kan? Medium. So that's why dia tak boleh nampak any stone if because the CBD is very distal. Kalau tengok dalam diagram, dia kecil dan distal. Dia duduk di belakang duodenum, right? Kan? Nampak kat situ from the diagram. So bowel gas ada kat situ, dia tak nampak because ultrasound is sound wave, right? But how do we know ada something yang obstruct? Of course, we have to look at the diameter of the CBD. That's why very important to look at the diameter of the CBD. The normal diameter is around 3 to 8 millimeter. If it is more than 10 millimeter, it's considered dilated. If dilated means ada obstruction lah. Yeah? Okay, continue.
Next. Next is ascending cholangitis. So choledolithiasis is like the obstruction in the above the neck of the gallbladder, like at, for example, at the common bile duct. So what happens when there is an obstruction at the common bile duct? There will be a bacteria from the duodenum which will ascend upwards and will cause infection. So that is what ascending cholangitis. So it is a bacterial infection of the biliary trees associated with complete obstruction of ductal system and occurs when biliary drainage is obstructed and superadded infection from the duodenal bacteria. So the clinical features are constant severe right upper quadrant pain, fever and jaundice, which we call Charcot's triad. So for the investigation, we need to do liver function test, hyperbilirubinemia, increase in AST and ALT. For the full blood count, increase in white cell. And ultrasound scan, there will be dilated common bile duct and air in the biliary system. There will be an air in the biliary system due to gas forming bacterial infection. And if we cannot found the stone, we need to do the ERCP and MRCP.
Okay.
Okay.
Charcot triad, Okay.
So this is the summary of what I have said just now. Next. Next is acute hepatitis. So the causes of the acute hepatitis, first is the hepatotropic virus, which you can see from the picture at your right side. It consists of hepatitis A virus, hepatitis B virus, C virus, hepatitis D virus, hepatitis E virus. Next is non-hepatotropic virus such as Epstein-Barr virus, cytomegalovirus, and HSV virus. Next is the bacteria, fungi, and parasites. So the clinical features are right upper quadrant pain with fatigue, fever, malaise, nausea, vomiting, and anorexia. And the patient may have icterus and jaundice, dark urine, and light-colored stool. So for the lab findings and investigation, there will be increase in serum bilirubin, increase in the ammonia, increase in ALP and GGT, increase prothrombin time, decrease in albumin, and other investigation are abdominal ultrasound and liver biopsy. Next is perihepatitis. The risk factor are the young sexually active women. So the causes are the Neisseria gonorrhea or Chlamydia trachomatis from fallopian tube to the liver capsule and overlying peritoneum. The clinical features are right upper quadrant pain with pleuritic component. So pain is sometimes referred to the right shoulder and there will be fever. So the investigation is the full blood clot, leukocytosis, increase in
Full
erythrocyte,
blood count.
increase in erythrocyte sedimentation rate, C-reactive protein, which will show photosensitivity and specificity, and laparoscopy. We will find patchy, purulent, and fibrinous exudate. Next. So that's all for me. I will.
Cuk. Hepatitis lalu tak datang ke surgical ward. Dia masuk medical. So what is the more common differential diagnosis of stone disease, of ascending cholangitis semua tu? Apa yang dekat-dekat dengan ni bila pasien datang dengan right hypochondriac pain, fever and jaundice? What is the differential diagnosis?
Pancreatitis, acute pancreatitis.
Yang tu still belong to gallstone disease lah. And the pain is in more central. Yang ni yang dekat right hypochondriac. Pain, fever and jaundice. Apa lagi? Differential diagnosis. Surgical cause. Surgical, masuk dalam surgical punya ward. Any other offer from the floor? Balan, bagi nama satu.
Bagi nama.
Tak apa, you duduk jauh kan?
Noah, Dr. Noah.
Noah. Bagi. Apa
Kidney
differential?
cancer.
Apa dia?
Kidney cancer, malignancy ke apa?
Oh, cancer dia jadi kronik. Dia bukan jadi acute abdomen.
Acute,
Lagi? Siapa lagi?
Trauma tu, trauma boleh ada.
Trauma bukan acute abdomen. Kita dah tahu apa sebab acute abdomen ni. Kita kena teka apa sebab dia kan. Tu acute abdomen. Trauma tu tahu. Cirrhosis tak cause pain. Dia cause ascites macam tu.
Hemolytic
tak apa.
anemia. Thalassemia
Anemia
severe.
Renal stone.
Thalassemia. Renal
Renal
stone
stone.
jauh dekat lambar.
Kalau small intestine obstruction, doktor?
Yang tu dekat central. Okey lah, kesian pula. Liver abscess lah. Kan, liver abscess dia akan datang dengan fever, pain and jaundice. Sebab dia obstruct kat situ kan. Because kadang-kadang dia too big. They can come with the jaundice. So how do you differentiate liver abscess with ascending cholangitis? Fikir balik, macam mana pasien dapat liver abscess? How do patient get liver abscess?
Kena tanya history of travel. Maybe because infestation of parasite.
What kind of parasite?
Apa nama dia? Sekejap.
Saya ingat nama dah.
Cacing tu dah.
Cacing, bukan cacing.
Hmm.
Bukan. Tu gonorrhea tu.
Bukan.
Bukan. Habislah you all ni. Nak kena hantar balik dekat microbe lah.
Ni amoeba.
What is the name? Cantik nama dia. Apa? Amoeba. What kind of...
Entamoeba histolytica.
Entamoeba histolytica. Kan cantik nama dia. Remember forever. Okay? Entamoeba histolytica. So how do you get Entamoeba histolytica? It's not from travel. Travel tu you akan dapat leptospirosis yang masuk ikan tu. Leptospirosis.
Oral apa? Anal oral.
Fecal oral kan?
Fecal oral.
So usually infected soil kan? You get from the soil. Okay? Right. So patient will get fever first. baru dapat jaundice and pain and jaundice. Kan? Because infection come first. Whereas in the ascending cholangitis, patient must have obstruction dulu baru fever kan. Dia kena obstruct dulu baru dapat infection. So patient will have jaundice first baru dapat fever. Right? And then ascending cholangitis, the cause is the stone. So bila ada stone to happen so long, dah lama. So patient will have history of what they call recurrent right hypochondriac pain. Dia akan dapat biliary colic dulu kan. Dia punya natural history. Dia dapat biliary colic dulu, baru cholecystitis, baru obstruction and ascending cholangitis. So from the history, patient will have recurrent right hypochondriac pain first. So that is the clue and beza antara liver abscess and also ascending cholangitis. Tu ada tu liver abscess tu. Okay. So uterus itu pneumonia, this is kita panggil pyogenic. Pyogenic kan? Dia ada dua kan? MEB and pyogenic. Kalau pyogenic is the systemic infection, usually from the GI infection. Whereas amoebic from the entamoeba histolytica tu lah. Ya. Alright. Bukan cacing ya. Okay, alright. Continue.
I will pass to my friend. Thank you, Doctor.
Okay. Siapa pula?
Ni. Assalamualaikum warahmatullahi wabarakatuh.
Assalam.
So, I'll present about liver abscess.
Oh, ya ke?
What? No need ya? Okay lah, tak apa. Next slide.
Okay, tengok kejap. Tengok x-ray tu, very interesting kat situ. You, ceritalah sikit, you ada x-ray kat situ kan?
For the X-ray, you can find there is elevated right hemidiaphragm and right basilar infiltrate or right-sided pleural effusion.
Kenapa dia jadi macam tu? Elevated right hemidiaphragm and ada pleural effusion on the right side. Why?
Because
Reason.
But liver location, the liver locate below the below the diaphragm.
Yelah dia akan cause the local inflammation there. Bila berlaku local inflammation there, the diaphragm pun dia akan jadi local paralyzed kat situ. That's why dia jadi raised hemidiaphragm on the right side. Betul?
Betul.
And then also it will involve the vessel of the lungs over there. So that's why dia akan jadi ada exudates and cause pleural effusion. So this because of the infection at the area. Okay, I want to highlight the fever of liver abscess. Okay, the fever, macam mana the pattern of the fever of liver abscess compared to other disease? Najwa?
the fever.
Sebab you nak beza kan, you nak buat diagnosis. Yang ini ascending cholangitis ke liver abscess. So you kena tahulah karakteristik of liver abscess ni macam mana. So the fever, I cakap tadi the fever will come first. Compared to ascending cholangitis, fever will come later. Kan? So fever come first, maybe 2 weeks preceded by fever. So macam mana fever ni?
I'm not really sure.
Not really sure. You buat slide ni tak baca ke?
High grade fever.
High grade fever with cheese and riders. Fluctuating kan? Bukan fluctuating macam apa ni? Ni kan. Tinggi kan. Fluctuating fever. That is characteristic of abscess. Okay?
Okay.
Okay, alright. Continue.
Okay, next. Next is the portal vein thrombosis or PVT. It is the occlusion of portal vein by thrombus. Patient might come with abdominal pain and abdominal distension. There also dyspepsia.
Okay, portal vein thrombosis. Portal vein thrombosis ni is not a cause of acute abdomen.
Huh?
Okay, it's not a cause of acute abdomen. Okay.
So,
alright, let's skip this slide. So this is not a diagnosis of acute abdomen. This is diagnosis by exclusion. Kalau exclude dulu baru kita jumpa yang ni. So it's a very rare kan? Very rare and it's not a cause of acute abdomen. Okay?
okay. Next slide.
Lagi?
Next is splenomegaly. It is pain or discomfort in left upper quadrant region. The pain might be related to left shoulder pain and with or without any satiety. So for lab findings, we may find immature or abnormal white blood cell, cytopenias, teardrop cells, spherocytes, and we can also do HIV tests and blood cultures if infection is suspected. Serologies is for chest X-ray, we can find pulmonary effusion, may associated with splenic abscess or other infectious disease, and also we can do the CT scan of biopsy. Slide.
Okay, splenomegaly also is not a cause of acute abdomen. Where did you get this slide? What is your referral?
I'm sorry,
Google.
this slide is done by another student, but we use the up-to-date website.
So salah. It's not. It's a chronic. Selalu splenomegaly. It's a chronic disease. So apa lagi acute abdomen? In the upper abdomen.
Any pain in the epigastric region.
Apa dia?
Fatty ulcer disease.
Najwa, boleh you buka you punya ni tak? You punya video.
Oh, okay, jap.
Sebab you presenter kan?
Oh, okay, sorry.
Presenter tunjuklah muka sikit. Baru ada skill sikit. Cakap. Right, okay. So what else? Tadi your friend dah tunjuk 9 regions. 9 regions.
Yes.
And that the organs involved, right? So what will be the common organs which has pathology for acute abdomen?
Stomach.
Stomach. Okay.
Yeah. Okay. Next slide.
Alah, yang ni bukan lah.
Okay. Next slide. Next second. So next is about the available. So next is the epigastric abdominal pain. These are few common causes of epigastric abdominal pain. Acute myocardial infarction, acute pancreatitis, fatty ulcer disease, gastroesophageal reflux disease, gastritis and infection varices. Next slide. Okay, firstly, acute myocardial infarction. It occurs when the freezes or stops to a part of the heart, which will cause damage of the heart muscle. Patient presented with epigastric pain, with feeling of indigestion or openness and gas. They might also come with sweating, shortness of breath, cough, nausea, and vomiting. How to make diagnose it is by doing ECG and cardiac biomarkers. And next, next is acute pancreatitis. It is sudden inflammation of the pancreas.
MI tadi. Habis dah ke?
Oh, done. Habis.
Tengok balik. Investigation, ECG, cardiac biomarkers. Epigastric pain with the feeling of indigestion or fullness and gas, sweating, shortness of breath, cough, nausea, vomiting. So macam mana kita nak tahu pasien ni dapat MI ke, dapat gastrik ke, macam mana?
By doing ECG.
Tak dengar.
By doing ECG or cardiac biomarkers.
Before ECG, clinical features, presentation. You are in the foundation, so kita nak you be kita panggil strong in your basic understanding, right? So macam mana you nak tahu this patient MI? Takkan tu je.
You can see the radiation of the
failure.
pain. Radiation of
Apa
the
dia?
pain. It can go to the severe. We can go to the jaws until and then the left arm.
Kan, ni ada basic description of pain in MI. Kan, dia ada referred pain to the jaw, radiation of the pain to the left sided chest, arm and jaw kan. And then dia mesti ada kita panggil autonomic nervous system punya ni kan. Right.
Sweating.
So it's sweating and all that. Lagi, what about the history before?
It have chest history of chest pain before.
Maybe this patient has history of hypertension, kan?
Cholesterol.
History of hypercholesterolemia, or maybe ISP ke before,
Diabetes
kan?
mellitus.
Dia bukan sikit je macam ni, tak cukup. And then what are the ECG changes? Apa ECG changes in acute? Najwa jawab. Dia yang prepare the slide kan? Najwa jawab. You answer me, not your friend.
ST segment elevation.
Apa dia?
ST segment elevation.
ST elevation. Semua? Kalau tak ada ST elevation, apa lagi?
Depression.
I'm not asking you, Mas Hakim. I'm asking Najwa. Najwa, you prepare the slide. You should know the best.
I'm sorry, I don't really know.
Apa dia?
Arrhythmia.
Apa dia?
Arrhythmia.
Arrhythmia lagi. What is the common or kita panggil pathognomonic for MI selain daripada ST elevation. This is very, very foundation. Okay? Each doctor should know this. You belajar start daripada first year lagi. Then you buang. You tinggal semua. Masuk final year tak tahu apa. Jadi doktor pun tak tahu apa. Jadilah useless doctor. Right? Okay? So what about cardiac biomarkers? What are they? Not enough by just tulis macam tu. You have to explain apa cardiac biomarkers for diagnosis of AMI.
Yes. Increase AST.
Apa dia? Cardiac biomarkers tu apa you nak? You nak order kat situ apa? Troponin apa?
Cardiac troponin.
Lagi? Ada S kat situ. Maknanya multiple lah kan? Plural.
Creatine kinase. Creatine kinase.
Creatine kinase. Lagi? Is it important to diagnose AMI?
Yes.
Kan? It should be at the fingertips. Okay, lepas ni you adjust your punya slide. Letak banyak sikit. What are the ECG changes? What are the cardio biomarkers? What the history and physical examination for AMI? Okay? Boleh? Okay, continue.
Slide. Next is acute myocarditis. It is a significant of the previous. Majority of cases have been secondary to prostate disease or alcohol consumption. So for clinical features, the pain is acute onset. It is persistent upper abdomen pain which radiated to the back. The patient might present with frequent vomiting, persistent nausea, and epigastric pain or palpation. For investigation,
Epigastric pain on palpation. Palpation tu sign, pain tu symptoms. Okay? Pain is symptoms. Palpation is a physical examination. So what is the signs of pain? Kalau kita nak tulis sebagai sign, kita kena tulis apa? Pain is a symptom. I know Basira jawab tenderness. Okay. So, selalunya third year punya slide ni dia third year ni dia rajin sikit daripada final year. Selalunya ni terbalik. Third year punya slide selalunya very heavy with wording. Nak tulis semua benda kat dalam. That is usually third year punya slide comparing to the final year. And I pun tahu third year should be very thorough. And then final year usually I just focus on the clinical side. Okay, untuk third year because you are foundation, you should be more towards pathophysiology and clinical application of your basic sciences. So ni I'm quite surprised lah with the slides macam ni. So selalunya kalau dia tulis causes, mana ada tadi? Causes of pancreatitis selalu banyak kan? You suka tulis banyak-banyak tu get smash semua tu kan? Kat mana tu? Tak ada, hilang. Tak penting.
tak ada. Mungkin tak penting.
Macam tak penting lah kan? Alright. So, tulis balik kat situ, what are the causes of acute pancreatitis? Yeah? And then, why is patient yang develop acute pancreatitis, the symptoms pun tak cukup tu. So, So, what are the classical symptoms? Symptoms of acute pancreatitis.
Low grade fever.
Salah. Classical symptoms of acute pancreatitis. Classic. Textbook. Siapa nak jawab? Soalan turun-temurun.
Acute pancreatitis.
Oh, itu pancreatitis lah. Classical symptoms dia.
Saya
Kalau
ingat.
patient,
Tak. Okay. Rise in jaundice.
tak,
Diabetes.
tak pastinya.
Rise in glucose level.
Tu Amirul Nazla jawab betul. Amirul, cakap Amirul boleh? Cakap. Baca balik. Relief by sitting forward atau leaning forward lagi. Aggravating by. Yes. Kenapa? Okay. So the pain radiated to the back. Satu, radiate to the back. Yang kedua, aggravated by supine position. Tiga, relief by sitting forward ataupun leaning forward. So that are the classical symptoms of acute pancreatitis. Kena ingatlah. Alright. So my next question is, why is that so? Kenapa? Kenapa dia jadi macam tu? Kalau supine lagi sakit, patient pun bangun duduk untuk hilangkan sakit tu. Kenapa is that so? Why it radiates to the back? Senyaplah. Jawablah.
Because pancreas is dia visceral, so it is the autonomic nervous system will akan cross dengan somatic, so it can somatic at the back, so it can cause back pain.
Salah. Visceral semua. Visceral. Bawah apa visceral? Why it radiates to the back? Aggravate
Because
supine.
the position of the pancreas is
apa dia?
is
Position dia.
behind the stomach, so
location. Kat mana location dia? Bagus. Nasib baik ada yang jawab betul. Retroperitoneal organ. So any retroperitoneal organ will give the same characteristic. Radiate to the back, aggravated by supine position, and relief by sitting forward. Contoh macam triple A kan? Abdominal aortic aneurysm. Sama juga. Dia radiated to the back as well. Radiate to the back also, pain dia. So, sebab dia retroperitoneal organ. Alright. Okay, so investigation serum amylase 3 times. Apa maksud 3 times ni? What is the normal serum amylase? Najwa. So, berapa nak kata this is acute pancreatitis? Berapa level dia? Guna yang USM punya.
USM
Berapa? Anybody? Tahu tak berapa?
30 to 110 unit per liter.
Yang normal up to 300. Kalau 3 times 900. So kita ambil 1000. If serum amylase more than 1000, it is a diagnostic for acute pancreatitis. Okay? Itulah saya cakap. Dia punya slide ni tak membantu apa-apa. Okay, continue.
Okay. Serum lipase, conversion test, and abdominal ultrasound. So, slide. Next is peptic ulcer disease. It's condition which painful source of ulcer develop in the lining of stomach or duodenum. The clinical features is epigastric pain, usually short duration, but can persist for a long time. And also, there is tenderness during palpation. For investigation, we can do the endoscopy to detect the ulcers and also complete blood count. Next slide.
Tunggu.
This is the, okay. Baik, patah balik.
Clinical features tak cukup. What are the clinical features? Boleh jawab, siapa-siapa nak jawab?
Dyspepsia.
Dyspepsia.
Dyspepsia. Epigastric pain. Pain tu macam mana? What kind of pain?
Burning sensation.
Burning pain. Okay, lepas tu lagi? Aggravating, relieving?
Aggravating when lying down.
Depends on the side of the ulcer, kan? Okay, contoh kalau gastric ulcer, what is the aggravating? What is the aggravating and relieving?
Food intake. When they take food, they feel pain.
When food intake, it cause pain. Betul? What about duodenal ulcer?
Duodenal ulcer, duodenal ulcer when
Najwa jawab.
Ya, apa?
Food reduce pain.
Apa?
They will eat frequently.
Tadi kita discuss. The presentation is according to the side of the ulcers. Kalau gastric ulcer, the pain is aggravated by the food intake. Kan?
Yes.
Duodenal ulcer pula, the pain is relieved by the food intake. Correct?
Yes.
Why is that so? Kenapa boleh jadi macam tu? Beza. Kenapa tak sama?
Sebab
I tanya Najwa lah, Mustaqim. Najwa jawab. Dia mesti baca ni. Dia buat slide ni. Ada gambar-gambar lagi tu.
Because this one is I'm not sure.
Not sure. Rawan jawab depend on pH level. Rawan, cerita sikit. pH level tu macam mana? What do you mean by pH level? Rawan? You ada mic ke? Senyap lah. Rawan. Yes. answer lah. It's a practice apa? Answering the questions. Oh, might not work pula dah. Siapa nak jawab tadi? Amira ni. Amira, jawab Amira.
Saya. Okay.
Jawab.
Because during food intake, there is a gastric excretion. So from the stomach, so it will cause the ulcer to the gastric will trigger the pain of the ulcers, gastric ulcers.
Okay.
But in duodenum, when related to regulation, when it go to duodenum, the gastric excretion from the stomach, from the gland of the stomach will become less, and there is increase of the liver enzyme. Like pH will reduce from the stomach, so that's why it's relief of the ulcer.
Saya tak jelas pasal yang liver tadi. Apa maksud dia?
They will secrete like bile, salt and so on to the in order to digest more food, macam contohnya fatty food. They release bile, salt in order.
So this is when you learn long time ago, you learn about digestion, kan?
Yes.
Bila food masuk ke stomach, asid hidroklorik dikeluarkan daripada parietal cell, C-cell semua tu mengeluarkan asid hidroklorik acid, kan? Lepas tu bila stomach, apa yang didigestkan dekat stomach, lepas tu dekat the stomach, the food then semi digested, dia pergi ke duodenum. Bila sampai duodenum, what happen in the duodenum? It cause contraction of the gallbladder. Gallbladder mengeluarkan mengeluarkan bile, because in duodenum there are other particles to be digested, which needs the alkaline, whereas in the stomach they need the acid. Ni belajar dah semua ni long time ago. Okay, so because when you forgot about the physiology, this is what happened. You don't know the pathology, you don't know the process. So bila sampai dekat duodenum, makanan sampai, the acid tu akan dialkalinkan oleh gallbladder punya bile daripada gallbladder, kan? Bila alkaline, so it cause less acidic and cause less pain for the ulcer there. So that is why the presentation is different between gastric ulcer and duodenal ulcer, which is not mentioned here. Alright. So what about the risk factors for peptic ulcer disease? Also not mentioned here. What are the risk factors? What kind of patients will develop these ulcers, peptic ulcer disease? Najwa? Risk factor ada tak?
For patients that use NSAIDs or corticosteroid.
Okay, NSAIDs, steroid, lagi? So bila you nak cakap pasal factors, you have to remember what is the factors that responsible to jaga the stomach mucosa, kan? So when there is imbalance between the factors that take care of the mucosa integrity dengan the factors that cause the break in the mucosa integrity, it will cause the ulcers. So NSAID, why NSAID cause ulcers? Macam mana NSAID boleh cause ulcers? Anybody?
inhibition of cyclooxygenase. Thus,
So,
the production secretion of prostaglandin. And
so prostaglandin in other parts is not welcome, but it is welcome in the stomach, kan? Kenapa? What is the function of prostaglandin in the stomach?
Stomach acid secretion.
Tak, bukan. Apa function prostaglandin in the stomach?
It inhibit the G cell to release the gastrin, so no HCl secretion.
I thought it cause mucosal production.
Oh.
It promotes the mucus production.
Okay. Alright.
So kalau kurang prostaglandin diinhibitkan, maka kuranglah mucus production in the stomach. Jadi maka kuranglah dia punya lining tu kan. That's why patient senang dapat ulcers. That is NSAID. Okay. So others lah macam smoking. What about H. pylori? Some of your friends mentioned about H. pylori. How do H. pylori cause ulcers in the stomach? Macam mana? Apa yang ada pada H. pylori yang membolehkan dia boleh duduk kat situ and then menjadi ulcer kawasan situ? Anybody? H. pylori kan seronok belajar pasal H. pylori.
it release toxin.
Aizul nak jawab. Release toxin.
Thus cause inflammatory response.
Tak juga.
Release urease lah tu.
Pandai.
Apa ini?
Release urease. Kan? Urease, urea. So urease ni dia juga break the integrity of the mucosa. And then dia ada apa? Flagella, flagellated. Kan? It's a flagellated. So it will go in the gap of the mucosa. So there are few process for H. pylori. In order for them to be happily jadi resident kat situ, dia keluarkan benda-benda ni. So later that will cause the break in the integrity of the defense mechanism of the mucosa in the stomach and cause ulcers. Very interesting to learn. Okay. Alright, continue.
Next slide. So this okay. Next is gastroesophageal reflux disease. It is a digestive disorder that occurs when acidic stomach juice or food and fluids back up from stomach into esophagus. The clinical features is heartburn, regurgitation, and epigastric pain. This is the classic triad. However, not all patients will experience all three. And then the symptoms are oftenly provoked by food, which is those that delay gastric emptying. For example, spicy food and fats. For investigation, the gold standard for diagnosis of gastroesophageal reflux disease is the 24-hour pH recording. It is to measure the amount of reflux in esophagus for 24 hours. Also, we can do endoscopic biopsy.
Okay.
Okay, next is gastritis. Gastritis is an inflammation of the productive lining of the stomach. The clinical features are abdominal discomfort or pain, heartburn, nausea, vomiting, and hematosis. And also, patient might come with loss of appetite, indigestion, have black stool, and the food feeling in the upper abdomen after eating. For investigation, we can do the complete background, and then we can also do the blood, breath, and saliva test, which is used to check for helicobacter pylori, and then fecal test to check for the stool, and endoscopy, the gastric tissue biopsy, and X-ray.
Okay, this is totally upside down. Haywire. Sebab gastritis should be first lah. Kan? Barulah ulcer. Gastritis should be first. Awal-awal ni cerita. Barulah ulcer. Dia kan macam progression of disease. Macam tadilah. Macam gallstone disease. Mula-mula kita start dengan biliary colic. Lepas tu inflammation jadi acute cholecystitis. Lepas tu obstruction dia jadi ascending cholangitis. Kita panggil spectrum of the disease. Okay, now when you talk about peptic ulcer disease, gastritis should be first. Mula-mula sekali. Gastritis dulu. Lepas tu makin teruk dia akan jadi ulcer. And then in this in this slide it is totally wrong because black stool tu is a symptoms of bleeding. And gastritis they won't bleed sebab dia belum jadi ulcer. Sepatutnya I duk tunggu yang ni black stool ni in the peptic ulcer disease. In the ulcer, gastric ulcer. When ulcerate baru dia bleed. Ulcer is discontinuation of mucosa, kan?
Yes.
Dia punya itulah kalau ambil slide daripada orang macam ni lah. Kan? So you give the wrong information to your friends. Okay? So hematemesis, black stool or any symptoms of bleeding is not in the gastritis. It is belong in the ulcer. Gastric ulcer or duodenal ulcer. So your investigation pun sama. Right. So the full blood count HB will be low in the ulcer disease which is normal in gastritis. Okay. H. pylori you boleh start daripada gastritis. So okay. But about the bleeding it belongs to yang dah jadi ulcer. Okay. Nanti you kena betulkan the whole thing. Takut nanti your friends duk baca you punya wrong slide ni. Ya. Okay.
Okay. Next slide. Next is gastroparesis. It is a disease in which the stomach cannot empty itself of food in normal way due to damage of vagus nerve.
Okay, gastroparesis is not a cause for acute abdomen.
Okay, next slide.
Yang ni kena delete slide ni.
Alright. Next is acute central abdominal pain. Okay, next. These are among the few causes of acute central abdominal pain. However, I want to all
Mercus diverticulitis is not in the center where it should be.
Lower part.
Kat mana? Lower pun kat mana? Bukan dekat central. Kat mana? Any answer from the floor? Fadlan, tadi you tunjuk kat mana Fadlan? Regions untuk Mercus diverticulitis?
Mercus diverticulitis.
Tengok slide you kat mana tadi? Which region?
Slide tadi yang awal-awal tu kan.
Yelah, awak kan buat slide pasal awak ingat lah.
Jana tunjuk yang slide abdomen region.
IBD ke doktor?
Mana pula IBD? Mekes tadi, I cakap mekes. Nuraini dah jawab. Nasib baik ada orang ingat Fadlan punya. Belongs to right iliac fossa. Kan? Kau tak ada kat sini. Tak apa. It belongs to right iliac fossa. It's a close differential diagnosis to acute appendicitis. It's not belong to the central. So, kalau you ingat tadi, kalau kat central you can imagine what are the structures in the central. Tak payah fikir, imagine je. Apa yang ada dekat center of the abdomen?
Intestine.
Aorta lagi.
Intestine.
Lagi. Small intestine.
Small
Kan?
intestine.
Ureter.
Small intestine. Basically tu je kan? Dekat tengah-tengah ni. Kan? And it could be pancreas jugalah kan? Right. Tapi kita dah cerita pasal acute pancreatitis. So now, apa dia you nak cerita? UTI of course lah. Salah. UTI kat mana?
Tapi kalau upper urinary tract kan
Dekat lambar, bukan central.
triple A.
Ada ke kidney dekat tengah-tengah tu? Ada.
Oh, central ni bukan yang dia like the whole three region yang bahagian tengah Dia tengah sahaja ke? Kalau sebut central.
Okay, kalau you nak cerita, you cerita by region. Kan? Kalau you nak cerita, you have to mention regions.
Okay.
Regions, right? Regions. So you are talking about the regions. So if it is central, it is periumbilical lah, dekat umbilicus tu. That is central abdomen. Right? Yang kanan kiri tu is the right and left lumbar region. Some students, some of us, we will have photographic memory. Okay? So if you show this slide, I will remember this slide. So this is very dangerous if you put up the wrong information in your slide, because sometimes we learn from our memory comes from our vision. Right? That's why I nak suruh you betulkan. Because some of your friends, dia ingat apa yang dia nampak. So you ingat the wrong information you have shown. Alright? So if it is central, confine to the central region, which is at the periumbilicus. So there are few only organs in the periumbilicus, which is central, which is small intestine and also triple A. Kan? So anything that the pathology belongs to small bowel. What are the pathology belongs to the small bowels? It could be intestinal obstruction, right? Lagi? Apa lagi? IBD, macam you mention.
IBD.
Lagi?
Mesenteric lymphadenitis.
Mana? Mesenteric ischemia. Okay, so those are the common diseases or presentation that come as acute abdomen. Kan? Intestinal obstruction dia tak selalunya dia tak ada untuk small bowel, dia datang as a acute compared to colon. Colon usually chronic, kan? But can also come with the acute. But usually small bowel will come with the acute abdomen. So our topic today is about acute abdomen. Jangan pergi jauh, kat situ je. Jangan confuse. Okay? Our topic is approach to the acute abdomen. Okay.
Okay, next
So
slide.
kena betulkan.
Right. Next lah. Ni tak betul. Next slide. So, the causes of central acute abdominal pain is inflammatory bowel disease. We can have it's either Crohn's disease or ulcerative colitis. The Crohn's disease is patchy inflammation throughout the small and large bowel. It can happen anywhere in there. And for ulcerative colitis, it is continuous and involve inflammation in the large bowel. So for Crohn's disease, patient might come with central or right iliac fossa pain. And then in the right iliac fossa, and tender terminal ileum may be palpable, and thickened ileum angiosum might be palpable in the umbilical region. Patient also might come with nausea, vomiting, and also weight loss and fatigue. For ulcerative colitis, the clinical manifestation is acute abdominal pain, especially when completed by acute toxic dilatation, perforation of the colon. And it is usually preceded by severe diarrhea, accompanied by passage of blood, mucus, and pus. For investigations, we can do endoscopy, check the inflammation, and then complete blood count, and also inflammatory markers such as celiac protein. Next. That's all from me.
Lagi mana yang IO semua tu tak ada ke?
Ah,
Yang IO semua tu tak ada ke?
I
Intestinal obstruction tak ada?
Oh, tak ada. I refer the browse.
Okay.
So, thank you.
Okay, Assalamualaikum warahmatullahi wabarakatuh, and very good evening to everyone and the doctor. And then next I'm going to be presenting about acute lower abdominal pain.
Ni
So
slide
this
yang
is the
sama ke?
no.
Tak, yang ni yang buat sendiri Nurul?
Yes.
Okay.
Okay, this is okay. I'm going to present about acute lower abdominal pain. So next is about the causes of lower abdominal pain. So we have here is acute appendicitis, acute metal diverticulitis, acute diverticulitis, nephrolithiasis, pyelonephritis, cystitis, infectious colitis, pelvic inflammatory disease, such pregnancy and diabetic. But the one that I have been highlighted is the one that I'm going to speak about. So the first one is acute appendicitis. So what is acute appendicitis is inflammation of appendix. So the clinical features for acute appendix is vague pain begins at the center of the abdomen, and then it will shift the right iliac fossa and become severe. And next is loss of appetite, nausea and vomiting, constipation, diarrhea, and also some may present with the symptom of generalized peritonitis. So what is the symptoms of generalized peritonitis is abdominal pain, nausea, vomiting, sweating, and sometimes rigor. Okay, next is about physical examination finding. So what we can examine for the patient is patient will have flush cheek, low-grade paresthesia, tachycardia, fetal oris. So fetal oris is a foul oral odor, commonly called as black breath. And then palpable lymph nodes in necks, enlarged tonsil, distended abdomen, and then right iliac fossa tenderness. And then the patient will have guarding and also Ruffsing sign. So Ruffsing sign is a pain elicit in the right lower end quadrant with palpation pressure. Then the patient may have a rebound tenderness. Solace test positive. So Solace test is to indicate irritation to the iliac psoas group of flexor in the abdomen. So how do we test for Solace test is basically the patient need to lie on the left side, and then the right right need to be flexed backward. And then if there is pain elicit, so that means the Solace test is positive. And then next is obturative test positive. So obturative test is basically to also indicate for inflammation in the regions of obturated internus muscle. So what the patient need to do is the patient need to lie on the back and then flex the hips and knee 90 degrees. So if that pain elicits, the obturative test is positive. And then next is rectal tenderness, and the last one is localized hyperesthesia in Sheridan triangle. So hyperesthesia is actually an abnormal increased sensitivity to stimulation, such as touch. And then it's happened in the Sheridan triangle. So we have three boundaries in Sheridan triangle, which is axis, which is anterior superior iliac spine, umbilicus and pubic asclepius. Okay, next is investigation. So what you
Kejap. Okay, so yang you highlight tu is not quite correct. Yang you highlight tu yang penting lah kan?
Yeah. Yes.
Kan?
Yes.
Pito oris is not the the sign of acute appendicitis. Okay? So you pernah dengar pasal Alvarado score?
Alvarado score. Yes. Next, I'm gonna talk about it here at the investigation.
Okay. So let's look at the Alvarado score. Tengok. So the symptoms and signs. Cuba tengok.
Yes. Alright.
Cerita lah.
Okay, I need to. Okay.
Baca Alvarado score tu.
Okay, basically we have 6 clinical items and then we have 2 laboratory measurements. So for 6 clinical item is pain migratory right to right iliac fossa, and then nausea, vomiting, anorexia. And then for the signs we have tenderness in right iliac fossa, rebound tenderness in right iliac fossa, elevated temperature. And for the lab finding, leukocytosis, and which is tenderness in neutrophils. But tenderness,
But apa?
Okay, but for tenderness in right iliac fossa and leukocytosis, we assign as 2.1 because it is like the most common factor in to score for appendicitis.
Yes, correct. Okay, let's go back to your previous slide. Cuba tengok dekat sini. Apa yang sepatutnya you red sign?
Pyrexia.
Pyrexia, betul? Kan? Lepas tu lagi?
Pyrexia. Right iliac fossa tenderness. Okay.
And rebound tenderness kan? Cuba tengok balik. The Alvarado. Tu ada rebound tenderness. Why lah you all tak connect all this? Kan? So that's why itu cakap photographic memory. Kadang-kadang kita tengok benda tu kan tapi salah. That's why before you present you have to make sure your information is correct. This is all the information. Kan? Fever, elevated temperature, rebound tenderness. Ada kan tadi rebound tenderness which you think tak penting. Right? You don't highlight. Tapi you highlight benda yang tak ada dalam ni. Okay? Right. So lepas ni betul kan? Ya?
Right.
So, kenapa migratory right iliac fossa pain is very important? What is migratory right iliac fossa pain? Migrate.
Because at the right iliac fossa pain, we have appendix.
Taklah, migratory. Ayat dia tu. Migrate daripada mana ke mana? Hidung ke perut ke macam mana? Migrate apa?
And the center of abdomen to right iliac fossa.
Apa dia?
Pain at the center, in the center of abdomen to right iliac fossa.
Correct. Mula-mula the initial state, patient will have pain in the periumbilical. Lepas tu, few hours after that or maybe one day, patient then have pain in the right iliac fossa. Okay, I won't ask you because you tak boleh jawab. I cerita je lah Okay, kenapa dia jadi macam tu? Sebab kita punya peritoneum, we have 2 layers, parietal and visceral. Kan, visceral tu yang dekat dengan organ, parietal tu yang luar dia kan? If you can remember our peritoneum layer. So, what happened in acute appendicitis? Initially, the visceral peritoneum inflamed. So just now, if you can recall, your friend mentioned visceral pain is non-specific and it will refer to the embryological punya memory. So embryological memory of appendix, it is belong to the which gut? Foregut ke, midgut ke, hindgut? Tak ingat gut.
Gut.
Ah? Apa Mustaqim?
Midgut sebab dia kat Amerika.
So midgut. So it actually belongs to midgut appendix. That is why dia ingat balik embryological memory dia is belong to the center because of midgut. But when the disease progress, parietal peritoneum is also involved. Dia pun dah jadi somatic pain. Somatic pain is the highly localized and sharp pain. Kan? So baru dia sedar dia sebenarnya berada di right iliac fossa. That's why it is called migratory. Dia tak migrate pun. Appendix memang dekat right iliac fossa. Tapi the pain perceived by patient because of this explanation lah. Faham? Faham ke?
Kita panggil dia McBurney point.
Apa dia?
Kita panggil yang ni McBurney point ke?
McBurney point, yes. McBurney point is the exact area where is the location of the appendix. So bila you examine the patient, you tekan at the McBurney point. That is in the sign. Faham?
Faham.
Tapi dalam gambar tak cerita pasal McBurney point. Tengok gambar-gambar. Tengok gambar abdomen. Dia cerita pasal Sharon's triangle which is not specific and it is not mentioned pun. Pada sesi ni jarang-jarang jumpa. Okay? Yang paling penting is McBurney point. Where is McBurney point? Where is tempat yang mana you letak you punya tangan masa examine the appendix? Kat mana McBurney point? Jana boleh tunjuk? You ada
Wait. At
tengah-tengah ke?
Distant laterally on line drawn from the umbilicus to the right anterior iliac spine.
Umbilicus and axis. Axis tu. Lepas tu kat mana point dia?
1/3 distance.
1/3 distal or lateral. Jangan dekat umbilicus. Dekat dengan axis tu. 1/3. You bahagikan 3 line tu. Okay. So, mana you punya cursor tadi? Letak dekat McBurney. Kat situ. 1/3 distal or lateral. Right? So, that is the location of the appendix. So, bila you nak examine, you letak tangan dekat situ. Palpate dekat situ. There will be tenderness at the McBurney point. And then, what about rebound tenderness? Apa maksud rebound tenderness?
Rebound tenderness means like if we palpate with pressure and then we like release the pressure, the patient will feel the pain after we release the pressure.
Okay. So, dia masa kita tekan tak sakit. Tapi bila kita release baru sakit. The explanation tu sama je sebab of the parietal peritoneum yang inflamed touch the abdominal wall. Tu yang jadi sakit. Bila kita tekan dia tak sakit. Tapi bila dia rebound, kan? Baru dia sakit. Because of the parietal peritoneum already involved in the inflammation. Faham ke?
Faham.
Seorang je ke faham? Ke semua faham?
Faham.
I takut I cakap seorang je. Okay, continue Najwa. Najwa pula dah. Jana?
Okay, next is as Dr. has said, we check for alveolar system and then through blood count, the patient we may have leukocytosis, which is high range of white blood cells. And then for urinalysis, we test it for whether the presence of blood for T cells and also for beta ICG to exclude the pregnancy. And then for imaging, we can do abdominal ultrasound, CT scan, peritoneal cytology, and the last one is we can do laparoscopy.
Okey. Kenapa kita nak kena buat urinalysis?
What? Urine.
Urine FME, urinalysis. Urine analysis.
Because we want to test for this for beta ICG to escape pregnancy so that the patient
Yang tu UPT.
Oh.
Yang atas tu.
Ni.
Urine FEME. Kenapa? What is the purpose? Tahu ke tak tahu? Tak tahu Ada siapa-siapa tahu? Nuraini jawab betul. Acute UTI. Kenapa kita kena exclude UTI? Because UTI, the treatment is non-surgical treatment. Kan? Betul? Betul tak? UTI kita bagi antibiotik je. Tak perlu buat operation. That's why we have to exclude that. Kalau kita go in buat appendicectomy, tengok-tengok patient white appendix. Lepas tu baru kita buat UFME is actually UTI. So salah lah our diagnosis and treatment. That's why you have to do the UFME to exclude the UTI. Right? Okay? Okay, proceed.
So next, the second one is acute mitral diverticulitis. So this is the most common congenital abnormality of the small intestine, which is result from incomplete closure of the vitellate, or we know as omphalar mesenteric duct here. And then this pathologic condition will produce signs and symptoms that are same as acute appendicitis, but the pain will more towards the center of the abdomen than in right iliac fossa. So,
okay.
The third one is acute diverticulitis. So what is acute diverticulitis? Is inflammation to microperforation of the diverticulum. So the clinical feature is the pain will shift the left iliac fossa, nausea, loss of appetite, constipation, diarrhea, increased frequency and painful contusions. And then for the examination finding, the patient may have pyrexia, tachycardia, and if there is generalized peritonitis or intestinal obstruction, the abdomen may be distended. And there will be reverse rhodopsin sign. As we put pressure on the right side, it may induce pain on the left. And then patient may have tenderness and guarding to left iliac fossa, rebound tenderness, abdominal duct impactations. Then for the investigation, we need to do the blood test, and then urine test, plain abdominal radiograph, and also CT scan. Okay, the fourth one is pyelonephritis. So pyelonephritis is infection in upper part of urinary tract caused by bacteria from bloodstream or up the ureter from the urethra. So what are the causes of infection is usually because of gram-negative bacteria such as E. coli, Proteus, Klebsiella, and Enterobacter. So the clinical features for pyelonephritis is patient may have severe pain in one or both loins, frequent and painful menstruation, which is during urination there will be burning sensation, and then the patient may have headache, malaise, nausea, and vomiting. And then for the examination finding, patient may have sweating and flushing. Urinary angle is tender when palpate. Guarding, urine may look cloudy and bloody stain. Then for the investigation is we may need to do the blood test, blood culture, which is we need to specify what kind of bacteria that have been infecting the patients. Then for analysis, ultrasound of kidney, RPU, which is X-ray examination of kidney and bladder, CT scans, and then for the management of pyelonephritis, we give parenteral, gentamicin, and cephalosporin, which has broad spectrum antibiotic. And then the fifth one is cystitis. So cystitis is infections of the urine within the bladder. As you can see here, the bladder, and then with a concomitant inflammatory reaction in the bladder wall. So symptoms of cystitis is patient may have increased frequency and urgency of intrusion, burning sensation or scalding pain, suprapubic tenderness, and hematuria. And this pathologic condition also may occur in young and middle-aged female, but also in young males with urethritis, elderly males with benign prostatic enlargement, and also bladder tumors. And next is acute spondylitis or women's as pelvic inflammatory disease. So pelvic inflammatory disease is infection in one or both fallopian tubes and associated with infection within the surroundings of the tissue around any cell. So the common causes of this disease is usually Gonococcus and Streptococcus. And this organism reach the fallopian tube by direct spread through the vagina and rarely from the bloodstream. And the clinical features of pelvic inflammatory disease is patient may have purulent, yellow, white vaginal discharge, lower abdominal pain, irregular menstruation, dysmenorrhea, painful and frequent menstruation. Then for the examination findings, patient may have feverish and flush, grinding and tenderness at the lower abdomen. Speculum examination, the patient may have fast discharge, and from the binary palpation of himself, patient may elicit pain. And then for the seventh one is ectopic pregnancy, which is the pregnancy in which embryonic implantation occur outside of the uterine cavity. So patient may have a history of delayed menstruation followed by 2-day history of mild abdominal pain or cramps. And some of the symptoms of ectopic pregnancy is abdominal or pelvic pain, amenorrhea, regular dark for vaginal bleeding, gastrointestinal symptoms, shoulder tip pain, and urinary symptoms. And the investigation that we can do to diagnose ectopic pregnancy is PPT, transvaginal ultrasound scan, transabdominal ultrasound scan, serial BHD measurement, and laparoscopy, and also the most basic one is FBC, PFTP, and that past match.
Okay, kenapa kita kena rule out ectopic pregnancy, inflammatory, PID and all that? Why? Okay, kita tanya pasal ectopic pregnancy dulu lah. Why we have to really exclude ectopic pregnancy from acute appendicitis? Contoh, pasien umur 21 tahun datang dengan right leg postpartum. So you tanya history pasal menstrual history, you tanya PV bleed, everything to exclude this, and you ambil UPT because to exclude this. Why? You rasa? Is it important? Yes, it's important. Why?
Location of the fallopian tube and the appendicitis dekat.
Yalah, it's a close differential diagnosis. That's why kita kena exclude. Tapi kenapa you kena exclude betul-betul? Kita tanya history, detail history to exclude this. Why?
Because of the management.
Case lain.
Management lain?
Ectopic pregnancy, gynae, surgical.
Discharge surgery. Kenapa? Yang mana lebih bahaya?
Ectopic.
Pregnancy.
What happened? Apa boleh jadi dalam ectopic pregnancy?
Rupture can be.
Ruptured.
Fallopian tube.
Kalau ruptured, okay lah. Beres lah. Beres ke dah best? What happened kalau ruptured?
Hypotension, lepas tu shock and then die.
Mati. Terus mati. Waduh. Bleeding. Intraperitoneal bleeding. Massive bleed. Patient will have hypovolemic shock because of the massive intraperitoneal bleeding. Right. So that's why kadang-kadang kalau tak cukup history, tanya history cincai-cincai, tak tanya pasal PV bleed and all that, you never suspect this is ectopic pregnancy, you tak buat UPT, you kata this is acute appendicitis, you admit to surgical ward. You faham lah acute appendix selalunya kalau kita post for lab appendicectomy pun bukan dia orang panggil terus kan? Betul? Kan? Dia orang pun letak dekat cubicle yang ujung-ujung, bukan acute cubicle pun. Right? End up, nobody notice this patient has bleeding. Patient might getting hypovolemic shock, bleeding, shock. And betul lah your friend mention, patient may die because of that. That is why very important to get the complete history in a lady in the kita panggil productive years. Yang umur 60 tu tak payahlah postmenopausal. Yang in the in the reproductive age, you have to exclude ectopic pregnancy because it is a kita panggil high mortality. Bukan saja-saja. That's why you have to ask. Sama juga dengan PID, pelvic inflammatory disease, it is actually non-surgical management. Right? Kalau it's not going into abscess yet. Kalau abscess memanglah we have to open up and then drain the abscess. But sometimes it's enough with the antibiotic. So that's why we need to get very good history to get correct diagnosis. So that's why I introduce you approach to acute abdomen to get the correct diagnosis. So this is actually just introduction. Later in final year, I will touch again about this topic, but more towards your diagnosis and then management. Tapi untuk year 3, I nak more towards why it happens, how it happens, kan? All about how you connect your basic sciences into the clinical years. Okay? Faham?
Yeah, doctor, I have a question.
Okay. Yes.
Can appendicitis be treated with antibiotic only? Ke kena buat surgical juga?
Okay. There is apa kita panggil conservative management of acute appendicitis. Sebab appendicitis dia ada dua, catheter and obstructive. Kalau obstructive tu dia akan progress. So yang obstructive tu tak boleh lah. We have to open up. Majority we have to do surgical management of acute appendicitis.
Thank you.
Lagi any other question? Ni apa ni presenters masa buat slide ada apa-apa yang tak faham ke? So you correct everything yang I mentioned just now and share back to your friends, ya? Kalau nak tambah, tambah lagi biar more information in your slide. Habis dah kan? So yang you tak sentuh tadi is acute mesenteric ischemia, central abdomen. Kan? Triple A dah ada sebut tadi. Tak ada juga kan? Triple A, abdominal aortic aneurysm. Laju ah?
Tak ada.
Tak ada kan?
Nanti saya tambah.
Dengan acute intestinal obstruction. Banyak juga tu.
Alright.
Okay. Okay, so that's all. Tak ada question dah? Kau ada tulis dalam sekejap. I baca chat. Alright. Okay, nampak tak ada question? Okay. So, that's all for today. Thank you. So, I hope later improve lah sikit. Siapa yang jadi presenter tu, try lah baca so that you can share your knowledge to your friends. Yeah? Okay, alright. Bye-bye. Thank you. Assalamualaikum.
Thank you, doktor.
Alright, thank you, Doktor.
Doktor.
Okay.